you, Jesus. Hi, everybody. Can you see me? I see me, but my mouth isn't moving. I guess this is all the time I've been on there trying to, I can't even hear me. Can you hear me, Dr. Nassiri?
Yes.
Okay, because I can see you. I just don't have any sound on here. I guess I'll just have to, let me put it on here and let me see us because I'm not seeing us on here. Sorry, everybody. I apologize for technical difficulty. I'm logging in now to our page so I can see us. Yep, I see us. Woo! Thank God. Yes, I am so sorry. Hi, Anne. I am so sorry. We've had technical difficulties because Facebook Live has just been giving me a hard time. So anyways, oh geez, so many people are on. I'm so sorry, everyone. Well, we're going to get to you. We had technical difficulties. Welcome to the VBF December 2024 Facebook Live with Dr. Naim Nassiri of the Vascular Care Group in Connecticut. Dr. Nassiri is not only VBF's newest expert, but he's the only vascular anomalist probably in the world, we know in the country, but the only person who's actually duly trained as an interventionalist and as a vascular surgeon. So he brings this massive wealth of information to us on understanding how to treat complex vascular malformations. He's also on the cutting edge with technology and research, and we've just been talking about some of his newest techniques and treatments, and I see there's a lot of you on with questions already. So I just wanted to introduce Dr. Nassiri and let you know he has been treating vascular anomalies and vascular malformations for many years. And welcome, Dr. Nassiri, to the 2024 December Vascular Birthmarks Foundation Facebook Live.
Thank you, Dr. Linda, and it's a pleasure to be here. I think this is our third one this year alone, so it's always been very well received, and I look forward to hopefully reaching out to more patients and being able to at least answer some questions for them.
Yep, well, we have a lot of questions already. So Anna is saying hi to you from California. Ria Louise, Sabrina, and Anne are watching. Okay. Sabrina says, my son is 7 years old and we are from California. He has a port wine stain that goes from the back of his neck, covering his back down to his feet and his foot. He has overgrowth where he has his birthmark, and the doctors have just approved him to start V-Joyce. You know about that. And he has not been confirmed with PIK3 mutation, and while other genetic testing has been negative. I was wanting to know if you have any other recommendations for treatment or any further advice finding a diagnosis. Dr. Linda and I have sent you, and I will resend it again after this meeting. So that's Sabrina Blackburn.
So I think, in the era of these medications, one thing I'm noticing is happening a lot is whereas before a lot of this pharmacotherapy was reserved for patients who had life or limb threatening or organ threatening malformations. They're now just being handed out like candy. And I'm starting to take a lot of patients off these medications because um, when you go and see somebody and rather than just an actual physical examination or a very thorough radiologic investigation, looking at the specific um, underlying vascular malformations, right? We tend to just do some kind of biopsy, send it for DNA sequencing, and then just throw the patient on medication and think that we've treated it. And I think that's really short-sighted. It's great that we have these medications. I think they're a helpful adjunct. I certainly have used them to patent and come up with new routes of interventional treatment. But I think to just throw the patient on medication, which will then cause a rebound effect when you take the patient off of it. Not only that, but also some of the long-term side effects of these things are not known. When you put these very young kids on these medications, these are really not benign entities. So I'm all for it, but like I said, a physical examination, a thorough physical examination, duplex ultrasonographic investigation of the areas affected, plus or minus MRI, along with hematological evaluation and scrutiny, all in the hands of one individual who can oversee and overlook the care of the patient is profound. And there are patients who have limb-threatening malformations, and they're just oh, we're on these direct PIK3CA inhibitors, or we're on rapamycin, or we're on whatever it is that's being used nowadays. Just to use that alone, I think it's not doing justice to the patient.
Thank you for that. Lori has a 3-year-old grandson, and she said he has a malformation in his mouth and that he was born with it. Are there treatments for that?
Oh, 100%. I mean, I treat intraoral, right? Means in the mouth malformations. We just have to understand what type of malformation it is. Is it most likely it's a venous malformation, but it could be lymphatic, it could be macrocystic lymphatic, microcystic, it could be mixed, it could be an AVM. If it's an AVM, it's a whole different ball game. We may have to do cervical cerebral angiography. We may do direct puncture, which, by the way, I do all of these in the comfort of my own office-based laboratory. In other words, I have an operating room in my office. The vast majority of these procedures need not be done in the hospital. So if anyone says that the hospital is the only place for this, they are wrong. These things, and my philosophy in treatment is small bite size, small bites of the apple, a little bit at a time goes a long way. And we can come to a curative measures. I used to rarely use the term cure when it came to malformations, but I'm becoming growingly more confident in what we're able to accomplish with the latest in technology and technique that we have available, plus ongoing experience. So my recommendation to you would be a soft tissue duplex ultrasound in the hands of somebody with expertise of doing those specifically for malformations, and it has to be a duplex. It has to look at color flow Doppler, it has to look at B-mode imaging, and it has to do a spectral waveform analysis. All those things combined with a thorough hematologic evaluation, followed by the proper treatment in the hands of someone who is well versed in the management and treatment of head and neck vascular malformations.
Thank you. So Lori can email you correctly, and
Yes.
you will be able to schedule through your office, a
Right.
consultation.
Yeah, and I want to just kind of let folks know, because I get a lot of out-of-state inquiries. Our office does a lot of work, a lot of hard work to try to convince insurance companies to pay for these. And uh, we have expertise in covering these. Sometimes, however, I may request that we do a telehealth visit, and there may be a very nominal startup cost. These prices are highly discounted through the Vascular Birthmark Foundation. But unfortunately, we have to go through some of these hoops to be able to convince the insurance companies to pay for treatment, so that folks are not charged with tens or hundreds of thousands of dollars for treatments. I don't do that. I don't charge people cash for these things. We work very, very hard to make sure insurance companies pay for it. So you may have to go through some sort of evaluation initially via telehealth or video visit to incorporate you into our system. Then I can put all the guards, if you will, out there to go after the insurance companies and make sure that we get reimbursement appropriately, as they should be, for these very tough problems that don't have a very good solution.
Thank you for that. So Anna, this is a very interesting case, Dr. Nassiri. Anna Camissa says she's 25. She has 8 port wine stains, 3 on her leg. She was also diagnosed with CM-AVM, Parks-Weber. She has 2 hits on Rasogene, one causing the CM-AVM, she said, and the other overgrowth. I've been told I'm not a surgical candidate. And over the past 4 years, I've been on 4 different chemotherapies, but don't want to be on meds. But I also don't want to risk my malformation getting any worse. Can you help?
Absolutely. I don't understand. First of all, who's telling you that you're not a surgical candidate, right? Just remember, folks, when you're a hammer, everything you see is a nail. So you got to make sure that you go to a multifaceted individual who's going to be able to take a look at the whole thing and tell you what the solution is. So if you, for example, may have seen a surgeon, and I'm a surgeon, so I can talk freely about this. And they say, well, if I go and start cutting into this thing, it's going to start bleeding. Therefore, you're not a surgical candidate. Well, that's not entirely accurate, right? Because there are a whole slew of interventional things that can be done to shut down the malformation. The other thing that's very important and severely under recognized, because there's really not too much vascular surgical expertise, is that we don't know what the hemodynamic consequences of these AVMs are. When you have an AVM, there's an abnormal shunting from an artery to a vein that dumps blood incessantly and repeatedly into your venous circulation. So you can have developed venous problems. That venous problems need to be treated and give you a lot of relief by alleviating the venous hypertension. That in and of itself may wind up being 50% of the therapy. So to say that there's nothing to be done and not do any investigation and not do detailed angiographic interrogation, not exhaust options for embolization to treat your veins, and then to be able to say, well, this is what would look like going forward, I think would be very short-sighted. I highly recommend that you try to make connection with myself or somebody else and really see what your options are, and don't take no for an answer.
I like that. And this is something everyone has to be aware of, that you're so cutting edge that you are seeing the future, which is the move from these chemotherapy agents to unbelievably minorly, if not even invasive procedures that can accomplish incredible results, correct?
Yeah, we've gone away from minimally invasive, right, to now non-invasive therapy, right? So let's just say, case in point, I believe the young lady who had the Parks-Weber syndrome, RASA one documented Parks-Weber syndrome. If angiographically, we are able to identify, for example, where the various what we call nidus or the hotspots of uh, the AVM are. Um, what we can now do, and I have the only first in human clinical trial approved by the FDA as an IDE or investigational device exemption clinical trial, to use ultrasound beams completely extracorporeal, meaning nothing enters the body. There's no needle, there's no catheter, there's no knife, there's nothing. The ultrasound beam is placed outside on the skin, doesn't even touch the skin, believe it or not. And we can actually use ultrasound beams to zap malformations. I just did a young man yesterday in my office around 3 p.m. in our office in Darien, Connecticut. We are enrolling in this clinical trial. It's a phase 1 clinical trial. I'm only enrolling 30 patients. Slots are extremely limited, but we are indeed enrolling patients. And I strongly believe that HIFU or high intensity focused ultrasound, along with some of its other technical counterparts, are going to be game changing, paradigm shifting techniques and technology that are going to completely change the landscape. And so while interventional techniques, such as the ones that I've employed and I've learned over the years, are still playing a very prominent role, as is surgery to some extent, if done appropriately and in the right times. We are now entering the era of non-invasive therapies. So minimally invasive, believe it or not, is becoming slowly an outmoded modality, and we're moving towards non-invasive therapy.
Phenomenal. Is Anna Camissa, the 25-year-old that has the Parks Weber, would she be a candidate for your study? And are you accepting applications, or how can people like find out if they could be a candidate?
Yeah, so absolutely. The answer is yes. We would have to take a look at her, physically examine her. We would have to perform soft tissue duplex ultrasounds. We would have to look at her, venous drainage patterns, see if there's any incompetence. We have to identify where the nidus, in other words, what is the architecture of the AVMs? Are there a Wayne-Yates type 1, 2A, 2B, 3A? 4, is it dispersed throughout? Exactly what are we dealing with? Are there specific foci of AVM we need to focus on? And if we can see those foci of AVMs with duplex ultrasound, which we often can, then most definitely she would be somebody we would enroll. But again, remember, slots are very limited. We're very picky and selective for this very first phase, which is a phase one. We will be rolling out a phase two and three very quickly. And once that gets rolled out, there'll be a lot more slots. But I would encourage folks to come and see me as soon as possible. I probably won't have any more slots. My last appointment slot is December 24th this year, but come January 7th, because I'm taking a little bit of break, but come January 7th, the doors are open. So I welcome folks to try to call the office and make an appointment as soon as possible.
Thank you, thank you, thank you. Ashley is a 54-year-old female. She has a port wine on her nose and forehead. She wants to know if it can impact the skull because brain imaging shows a large vein that runs from the port wine stain to her brain.
Um, Again, without having seen the image, I don't know if this is a true MRA or MR venogram or MRI with contrast. I don't know who ordered and what the protocol was. What I would say is that it depends on what your underlying malformation is. If you just have a port wine stain, then the likelihood of you having an underlying malformation, if that's been documented either angiographically or with MRI, then there really isn't a whole lot to worry about. Remember that port wine stains are capillary malformations. In essence, you can kind of think of them in a very kind of as like a little venous congestion sponges. I think those are very important analogy to kind of think about port wine stains. But it depends on what your distribution is and what your underlying malformation is. Again, I would recommend a proper MRI, which then should guide the need for performing a diagnostic angiogram and or a soft tissue duplex ultrasound. The combination of those three modalities should give a definitive answer along with a thorough physical examination of exactly what the diagnosis is. And based on that diagnosis, for example, if we find out that you have an arteriovenous malformation and that draining vein has developed as a result of ongoing venous hypertension for many years, then that's a whole different ballgame for treatment. Or if we identify that you have multiple foci of venous malformations and that the port wine stains are merely a manifestation of those underlying venous malformations, well, then that changes the therapeutic approach as well. So it all really depends on what the malformation is.
Yep, thank you for that. And by the way, for all of you that are on, Dr. Nassiri has done a couple of these with me, and you can go to our website at birthmark.org, click on our YouTube channel up at the top, and you can search for him and see the other Facebook Lives that I've done with him. And yes, Nayli, he is from Connecticut, as I mentioned. You can set up an appointment. Gina is responding on here, our office, our communications director, and she just put Dr. Nassiri's email on there so that you can follow up with him and he'll have his staff reach out to you to set up an appointment. And she also wants to know, why did you focus on vascular birthmarks?
I thought it was a fascinating arena that many people were afraid to get into, and by virtue of my sort of training background, I realized very early on in my life that I have a novel way of looking at things, whereas a lot of doctors were sort of limited in their scope, whether there were surgeons or plastic surgeons or ENT surgeons or hematologists or radiologists or neurointervention radiologists. Everybody kind of focused in their own realm. And I thought of myself as sort of this intervening hybrid that was able to bridge the gaps. And then I realized that it was kind of this scary looking monster, and that rather than run away from it, if you stare at it directly and you stare at it directly long enough, it starts to kind of fade in the light of your presence and awareness, and that persistence over time pays off. And that has grown into probably one of the largest, if not the largest, uh, vascular malformation practices globally, and really the only vascular surgeon who treats these. And I think I bring a level of expertise and perspective that has been unheard of thus far in this realm. And working with the entities such as the Vascular Birthmark Foundation, our hope is to be able to answer a lot of the questions and kind of redirect the chaos and confusion that has plagued this field for many, many decades and unfortunately continues to do so.
Boy, that was well said. So Brooke Mitchell has a question. I was born with 2 birthmarks on the top of my head. One of them got smaller on its own. The other one ended up getting removed due to shape shifting. The spot where the scar tissue is now is tender. Is that something I should be concerned about?
Yeah, I would recommend getting a contrast enhanced MRI. I'm not sure what happened and why they did that, but it sounds like a typical scenario where somebody goes in and without adequately devascularizing a vascular malformation performs surgical intervention. And folks, remember, inserting a knife directly into a malformation is like fertilizer to the malformation. It loves it. You are causing the malformation to grow. And this is a surgeon telling you, right? So I don't want folks criticizing me, surgeons out there. I am a surgeon and I'm telling you, without adequately shutting down the blood supply to the malformation, you go and start introducing needles and knives to the malformation, you are making that malformation come back with a vengeance within scar tissue. So I've seen this scenario so many times. So my recommendation to you is get a contrast enhanced MRI, not an MRA, not an MRV, contrast enhanced MRI, and have someone who knows what they're looking at look at that MRI for you, and then we can discuss about treatment options.
Excellent. Orla says, my daughter has a venous malformation between her upper lip and nose. She is nearly 2 years old. Can you recommend a treatment? The MRI shows that it also passes under one cheek, but this is not seen on the surface. So it looks like
Again,
there's a deep component too.
yeah, so it sounds like we have to know what kind of malformation, right? There's different kinds. Most likely,
She said this is venous.
okay, yeah, venous malformation easily treated. In fact, I just published, I was in Madrid at the ISPA meeting. Dr. Linda was there. This is the International Society for Study of Vascular Anomalies. And we talked a little while ago about high intensity focused ultrasound, which is a technique that I have available. And I'm the only one in the United States that's using it. In fact, the only one globally that's using it for ablation under the United States Food and Drug Administration's approval as an IDE. The other thing I have patented is we talked a little while ago about these medications that a lot of our non-surgical, non-interventional colleagues are giving to patients, direct PIK3CA inhibitors, rapamycin, sirolimus, and many other chemotherapeutic agents. Well, I just published a paper. Folks, please look at it. Journal of Vascular Surgery, Venous and Lymphatic Disorders. I've actually given a copy to Dr. Linda. I'm sure she can post that. This is the first time ever, this is the first in human clinical experience using these medications, but repurposing and reformulating them. So rather than giving it to the patient by mouth or exposing the entire body of the patient to these medications, I can actually take these medications and inject them directly into the site where the malformation is. So for this young child, 2-year-old with a venous malformation of the head and neck, that would be a perfect patient who would be an ideal candidate for direct embolization of that lesion with a molecularly active agent that instead of giving that medication by mouth, we are just giving it directly at the site and significantly reducing the total dose as well as the potential for side effects. So that publication is out there with phenomenal pictures and descriptions. Again, this is the first in human clinical experience. I encourage all parents and all patients to go ahead and read that paper.
We will be circulating that in our professional publications corner. So that will be on our website and on our Facebook page very soon. We do have it. We did make it available, but I'm going to put it out there more prominently. By the way, Dr. Nassiri, the little 2-year-old that you were just talking about, I'm a little concerned because her mom just wrote and said she's waiting for sclerotherapy, but wondering what you would recommend.
Well, sclerotherapy with what? Again, that's important. And it's also important that you don't just, go to a place where they'll do a couple of injections with whatever's available, be it ethanol, which I would not recommend. Like I said, I'm a descendant of Bob Rosen, and we highly advise against ethanol in a lot of these cases because of its just toxicity profile, in my opinion, does not justify its use. I know that a lot of folks, I've gotten heat over the years for not advocating for ethanol. I know Wayne Yakes is someone who's really championed this, but again, the side effects and complications I've seen with ethanol, some of which can be lethal, to me just does not justify its use. There are other agents that are available. I think folks predominantly use bleomycin in the head and neck, but like I said, just really do your homework. Make sure the whoever you're seeing is going to be someone who's going to comprehensively care for your child, that is not just there as a technician, but can manage all aspects of it, not just the sclerotherapy part, but for example, has your child been evaluated hematologically? Has your child been looked for localized intravascular coagulopathy? Do you know what your child's D-dimer and fibrinogen levels are? Do you know if your child has flea bullets embedded within the malformation? So it's not just a technical practice of just zapping this with whatever you got available, but it's a matter of comprehensively caring for the patient and managing all aspects. So that individual, whoever it is caring for your child, really should have that within their arsenal to be able to care for that child comprehensively and look at all those elements. Maybe your child needs to be placed on anticoagulation. Are they comfortable prescribing anticoagulation to a 2-year-old? What kind of anticoagulation are they going to recommend? So on and so forth. So do your homework.
Well, it sounds to me like exactly what you're saying, because I've been seeing this for 30 years, is we've kind of accepted this continuous recurrence of relapsing and growth. And what you're saying is, I really believe this too. People can do like embolizations and sclerotherapies, but if they're not doing a comprehensive workup, these are going to come back for many reasons because they haven't looked at the D-dimers or the fibrinogens or to see if there's flea bliss. And then they pop up. And so people are in this catch-22 of getting a treatment, feeling good. It comes back, they're back in there, they're back in there, they're back in there. And this
Correct.
makes sense. So, I mean, just out of curiosity, because you are such a comprehensive physician, do you see a significantly less recurrence rate?
It's a hard question to answer because the malformations are like our handprints, our fingerprints. That's how sort of everyone is different. And so it depends on the malformation. And that's why it's so important to use the proper agent. Sometimes you may want to use something like glue. Sometimes you may want to use bleomycin. Sometimes you may want to use sodium tetradecyl sulfate. Sometimes you may even want to use more toxic agents occasionally, but it all depends on the extent and what your approach is. To me, if you say, hey, I see a malformation, I recommend 5 small bouts of treatment rather than one big whack that's going to leave you debilitated or disfigured. But I recommend, 3, 4, 5 sessions of treatment spread out throughout 1 to 2 months. I don't consider that recurrence. I call that a staged approach, a staged, least invasive approach to curative treatment of malformation. Sometimes our goal in malformations may not be complete cure. Our goal may be to give the patient a good enough quality of life to get the beast, if you will, the malformation beast that is, under leash and under control and keep it at bay. I've had multiple hand AVMs, for example, that have come my way, where I would say these patients are by and large cured. Whether is the AVM completely gone? No, it's about 95% gone, but that patient has functional use of their hand. They're not going to bleed to death. They're not in high output cardiac failure anymore. They're not debilitated and they don't have imminent nerve damage. I would consider that a curative entity. And it took 4 to 5 sessions for me to get there without adjunctive surgery, without a single knife or blade. So it all depends on what the malformation is and what the ultimate goal is. I think we have to put everything within the context of what the patient wants. What is our goal? It's called shared decision making. And that's why communication between doctor and patient's family becomes very important.
And that patient, the other thing is you're not keeping them overnight.
No, I would say 100% of my procedures are ambulatory at this point. I have not kept anybody overnight over the course of the last year and a half, 2 years now. I only require general anesthesia for very, very young kids. But if they're actually super young, like 1 month, 2 month old, right now I'm caring for a patient comes all the way from California. Child's a couple of months old and is was on the verge of losing the toe, and they were offering an amputation. And now we're performing sclerotherapy, which is actually not painful. These are really not cases that require general anesthesia. Mom and dad, they come into the room, into our operating suite. They see what is being done. I don't think anywhere else you can go where you have parents come into the operating room. Mom and dad come, they help us, hold the foot steady. And it's basically like it's no more painful than getting blood drawn. That's as painful of an operation it is. And these patients are literally, these are very short procedures, but we can do a lot of good in a very short period of time. So don't think that everything needs to be just this big giant whack. Uh, if and when the time comes and we do need to perform surgery, I will do it myself, unless it's like in the brain, for example, where I need a neurosurgeon, or if it's somewhere where I feel like I need the help of a colleague, or if it's in a very cosmetically sensitive area, I may request the assistance of one of my plastic surgery colleagues to cosmetically fix the area. But aside from that, we do everything ourselves, not to mention the option of high intensity focused ultrasound, which doesn't require you to cut or touch anything at all. So we have many, many tools available to us. Again, seek a second and third opinion, and don't just take no for an answer. And don't just think that if someone just gives you medication, that's it. That's all I got. Here's some, some PIK3CA inhibitor, or here's some rapamycin. Let's do some blood draw every 2 to 3 days. Take the medication twice by mouth. Oh, and take this antibiotic on top of it to make sure that you don't get an opportunistic infection. Oh, and here's this cream for your rash that you developed, and here's a oral solution for your mouth sores that you developed. So I would really seek out the likes of Dr. Linda and see what other options you may have, and don't think that what you've been told, that's all there is.
Well, that was exactly what I was going to say first. Bravo on the baby, because that was the baby that I brought from California to New York. The family drove with that new baby just to see you because they were told that baby would have to lose that toe. And I knew if there was anybody that was going to save the toe, it was going to be you.
Yeah.
And I'm just so happy to hear that. Louise from Australia is on, and she says her 9-month-old daughter's been diagnosed with a capillary malformation, which covers 90% of her back, 50% of her stomach, and 50% of her face. She wants to know, is there anything other than laser?
If it's just a capillary malformation, again, before you embark on laser, just make sure you're not dealing with an underlying malformation somewhere. It does not sound like it. There's some good folks in Australia who really know what they're doing. Just make sure that you're not dealing with an underlying vascular malformation. And that child is a little bit too young. Sometimes when you just have these capillary malformations, you won't know until the child hits puberty whether or not there is an underlying malformation. Sometimes if you have very characteristic patterns of port wine stains or capillary malformations, you can kind of a priori diagnose. But again, it just requires the astute eyes of an experienced clinician to determine when and where to obtain radiographic images, and to clinically correlate the findings together and come up with a diagnosis and know when and where to look for underlying malformations.
Thank you for that. Oh, I'm so excited to see this next question because it comes from John Berker. You met him at the clinic. John was the vice president of my board of directors.
Yes, I
And
remember him.
yeah, so for all the moms out there with kids with KT or Sturge Weber, John was an attorney general with New York State government. He is an accomplished lawyer and an international competitive biker. And he just did 7,350 miles this year. He writes and says he was very happy to meet you, and he wants to make an appointment to come and see you because he now has a bump below his right wrist and the veins on the back of his leg, which you informed him he needed treatment. So he is going to be making an appointment to come and see you.
Happy to see him. He was really a pleasure to get to know.
But again, here's where we're talking. He's going to be able to get a treatment from you and drive home,
Yeah,
right? I
exactly.
mean, this whole, like you said, we demonized vascular malformations, but rightfully so. They were nasty monsters that every time somebody operated, they came back with a vengeance and they caused disfigurement. But that was then. What you're talking about is the now. That's why we have these live sessions with experts that are new, with innovation like you, because you can say to the parents, demand from your doctor that you get referred to somebody, or demand that they learn these new techniques, because there's no need for them to have procedures that should no longer be done
Right.
because of what we have access to now.
Correct. I agree. I
And
couldn't
a
agree
lot of
more.
people are on just thanking you and thanking you and thanking you. And Veronica says, I'm a 65-year-old woman who has had treatments at the age of 7 with Dr. Goldman, often referred to as the father of laser surgery. I don't know about that because Dr. Geronimus or Dr. Anderson is the father of laser, but okay. Over the years, I've undergone a dozen laser. At this stage, is there any specific laser you would recommend? It covers the right side of her face. Now, what I'll say to her is Dr. Geronimus is the only one in the world with the V-Beam Pro. So go see Dr. G in New York City if anybody wants the best laser. Now, this second part is for you. She said, my port wine covers the entire right side of my face, and I have developed a bump under my eye and very close to it.
Again, again, if you've only seen a dermatologist, I love my dermatology colleagues, but I think they're all vastly different, right? You want to see a dermatologist who's astute enough to say, hey, this is not just a port wine stain. We need to do some further investigation, and sends you to the right person. You just got to make sure that you're not seeing someone who's just zapping your malformation with laser, because sometimes the port wine stain is just the tip of the iceberg that's signaling to you that there's an underlying malformation. And the more and more you poke the bear, by lasering, you can actually make things worse. So make sure your dermatologist has ruled out that you indeed do not have an underlying vascular malformation or a venous malformation. If that's just a capillary malformation or a variety of Sturge-Weber kind of configuration, by all means. And not only that, just remember, even with port wine stains, when they get super hypertrophic, or in other words, they get really overgrown and they get dilated, it would benefit from some sclerotherapy underneath to help depressurize, take the pressure of the vein off so that the laser can do what it needs to do. So without really seeing you and without examining you, this is pretty much all I can say. I would recommend a clinical examination and at least a soft tissue duplex ultrasound of the area to make sure we're not dealing with something more serious.
And two, remember everyone at our super clinic in New York, Dr. Nassiri is there, Dr. Coletti is there. We offer the free ultrasounds, we offer the free dental, we offer the free laser, we offer the free consultations. So, and many people met Dr. Nassiri at our clinic and are now his patients. As a matter of fact, Carrie Fredericks is writing to us from Charlotte. I don't know what happened to
No,
Dr.
I'm listening. I'm listening. Just some
Okay,
technical
okay, I guess you
changing
went,
my.
thank you. Thank you for being there, but I don't know what happened to you on the
I'm
screen.
gonna come back live as soon as I charge my phone. Go ahead.
Oh, okay. So I will read, so Carrie is from Charlotte. And first of all, she wants to thank you because you responded to her email that she sent you a few months ago. You'll remember she has a 3-year-old grandson and they had the MRI at Duke when he was 2. They said it was a venous malformation. At that time, they are choosing a wait and see approach. It's on the side of his face near the eye. My husband and I are very concerned, both in healthcare. The lesion is growing and he is due back at Duke. He has only been seen by ped dermatology, although a team reviewed his MRI and he does have labs. Just really sounds to me like they need somebody like you, Dr. Nassiri, a comprehensive vascular anomalist, that can look at and put all these pieces together.
Yeah, I agree. I mean, I think I do recall. I apologize. I see hundreds of patients, and I don't remember the nuances of every single one unless they are regular. But I would say that you need more than just a dermatologist for something like this. You need to be comprehensively sort of evaluated and looked at. I would advise strongly, strongly against watchful waiting. That's going to do nothing more than to have the lesion continue to grow. I'm not sure what in the hell we are waiting for. Are we waiting for the lesion to grow into the eye and cause problems, and then we're going to go after it? Or would it not make more sense for us to get ahead of the beast before it erodes into vital organs? So the lesion needs to be evaluated, venographically interrogated. We have to make sure there's no shared blood supply or blood drainage with the eye. And I would go after this thing yesterday, as soon as possible. Do not wait anymore. Get it treated. Make sure you go somewhere and get it treated done. Do not laser this thing. And again, go somewhere where it's not just one person punting you from one person to another, but there's one quarterback that is overseeing that. There's nothing wrong with multidisciplinary teams. I'm all for it. But there needs to be one captain of the ship who oversees the whole thing. You should not get punted from one person to another. Go to this guy for the laser, go to this guy to get your sclero. Oh, we did 2 scleros. Now it's not coming back. Well, I'm not sure what else we can do. One person needs to oversee your care, and that person will not and should not give up on you whatsoever. I tell all my patients, this is your home. I don't care if you develop diarrhea because of your malformation. I want you to come to me. If you have a mental breakdown because of your malformation, you're going to come to me. Now, does that mean I'm a gastroenterologist or a psychiatrist? No, but I'm the captain of this ship. I'm your quarterback. This is your home. We're going to be lifelong friends. And if I need to go and find somebody for you, I will go ahead and do that. But that's the level of commitment that folks need to make to malformations and the patients. So make sure you have one captain of the ship who oversees the care and evaluates all the hematologic components, all the cosmetic components, everything together, and then we can really come up with a good solution. But don't wait on this anymore. Treat it now.
Thank you for that. And since we did get stuck a little with not getting on, we'll run a little over because you do
That's
have a
fine.
lot of questions.
No problem.
So Dory Harmeyer said, the doctors are wanting to do sclerotherapy for my 3-month-old for his lymphovenous malformation in his tongue and floor of mouth. He will be 5 months old when we visit with the vascular anomalies team. Do you think there could be any other treatment other than the sclerotherapy? I'm worried since it is in his face.
I wouldn't worry about the location. I think if it's an experienced individual who knows what they're doing, that is the opportunity. That's what I would offer. Again, sclerotherapy, embolization just depends. Just make sure it just requires, angiographic interrogation or image guided sort of injection, which really should be an embolization, not sclerotherapy. And inquire about what they're using, so on and so forth. There are other options, including surgical excision. But again, I would not recommend surgery as first-line therapy because in that area, it can be very disfiguring, number one. Number two, without adequately shutting down the blood supply to the malformation, by going in blindly and doing surgery, you can actually make it worse. So in the right appropriate hands, I would not let sclerotherapy worry you. We do sclerotherapy and embolization on the face all the time.
Okay, thank you for that. Sierra Hernandez says, my daughter is about to turn 3. She had a biopsy done when she was 1.5 on her malformation. They did do an MRI with contrast, and that led them to decide to do a biopsy. But they told me that they are not sure what exactly my daughter's type of malformation is, since the biopsy they took from her on her cheek was not big enough sample. They have recommended me using hydro cream on it to help with the color and growth of her malformation on her cheek, but I'm not sure what to do. Do you have any recommendations? I'm now getting worried about how you mentioned cutting into a vascular malformation can make it worse. And I did not know that at the time of my daughter's biopsy until now. Please let me know what you think I should do. I have noticed after her biopsy that the malformation on her cheek has got more darker in color and has grown.
Yeah, obviously. So so my recommendation to you is if someone knows what they're looking at with MRI, they don't need to go and do a biopsy. Biopsy doesn't do a darn thing for malformations. You cannot tell venous from AVM from a biopsy. It is absolutely useless. Unless someone is going to take that tissue and do DNA sequencing on it, which again is redundant because if you have an MRI, and if you're experienced enough and you're looking at it, you will know exactly what type of malformation it is, and you don't need a quote unquote biopsy to tell you that, nor do you need to do DNA sequencing because we know, for example, if it's a venous or lymphatic malformation, by and large, it's going to be somewhere along the mTOR pathway that's implicated, nor would that make a clinical difference unless you're planning on putting the patient on some type of medication. So a lot of these things are sometimes I feel like it's just, we're just doing it just because we can. So I would get that MRI in the hands of somebody who knows what they're reading and looking at, and that individual should probably do their own soft tissue duplex ultrasound. And that combination, right, of a physical examination, duplex ultrasound, and MRI should give you a definitive diagnosis without all this horseplay. I've never heard of any cream or anything like that. There are some topical agents that are now available that folks are using. There are PIK3CA inhibitor topical agents. Some big time pharma companies are starting to take a look at it. I believe they're still under clinical trial. One of them may actually be FDA approved thus far, but again, these have minimal penetrance. They can only treat them if they're very superficial. They're not going to do a darn thing for deeper lesions. So I do think that you probably are going to benefit from sclerotherapy slash embolization, but get that MRI in the hands of someone who knows what they're looking at, and you'll have your diagnosis. Don't let anyone else do any more biopsies because you're just going to make the malformation angrier.
That's a good point. Now Teresa Marie, don't be upset. She's kind of upset because she's listening to us, and now she's stressed that her 3-year-old daughter had just had bleomycin last week by IT. I don't know what that, oh, I don't know what that means. CVAP diagnosed him with capillary malformation and lymphatic. During surgery, the IR found an artery was involved. We spent 6 days at CHOP.
I mean, these things are normal. I mean, that's not there's nothing to be upset about. But it sounds like this is an arteriovenous malformation, which they may have thought that it's some kind of a low flow malformation, but they encountered the high flow component. I don't think any harm is done, but again, you just want to make sure you have someone who really knows what they're looking at and is not just doing some investigational work. Somebody needs to, the way I approach these things, let's find out what it is, and then let's go in confidently, right? I don't do any of this horseplay. I don't know put some of this on, no. We need to give a diagnosis. This is our diagnosis. This is what we need to do going forward. These are the risks. These are the benefits. This is the side effects. So someone, whoever it is, needs to move in confidently, right? You don't want to have someone go in and just kind of do willy-nilly work. So my recommendation to you again, find someone who can give you a confident diagnosis and give you a game plan. If somebody can speak to you confidently, say, this is what I think this is what we're going to do. And folks, we are in that era. Long gone are the days of saying, well, no one can, if anyone tells you that you can't diagnose a malformation properly, that probably isn't the right individual for you. We
Correct.
are now in what we have available, right? If someone is experienced enough, they should be able to give you a diagnosis and then lay out a therapeutic plan for you. This is option A, B, C, and D. This is what we're going to do. Your diagnosis is X, right? None of this horseplay investigation. Oh, we went in there, we found an artery. Oh, we found a vein. But from what I'm hearing, I don't think any harm has been done. But just make sure that you are dealing with a confident team who can give you and lay out a plan for you. So that would be my
Yeah,
recommendation.
I'm a little concerned because I can kind of suspect that the baby spent 6 days at CHOP because they found that artery and it's probably arterial, like you said, and they're like,
Right.
what just happened?
Right.
Right? Because that's what happens when they discover it's high flow like that, when they're going
Yeah.
in thinking it's low flow, and then they're like, oh my gosh, what are we doing here?
Correct. Again, I'm a huge proponent of soft tissue duplex ultrasound. It gives you a lot of information a priori. Again, it may be in an area that's not accessible with soft tissue duplex. So again, I'm not criticizing anybody, but um, we should be able to have a definitive sense of what it is. Sometimes you may have to do a diagnostic angiogram to give a diagnosis. There's absolutely nothing wrong with that. There's nothing wrong with going in there and say, "Oh wow, listen, we found this to be an AVM." So again, I don't think there's any harm done, but I'm not sure why there was 6 days stay in the hospital. I wasn't there, so I
I
can't
know.
really comment.
I'm just
So
surmising. I think I'm probably right that they went in thinking it was one thing, and then they got in there and saw it was.
yeah, that happens a lot. Yeah.
Yeah. Now Sierra wrote back again, and I just want to say, Sierra, that I really think you should go see Dr. Nassiri, because she's saying, I forgot to mention, they're not sure if it's venous or lymphatic, even though they did a biopsy. And she said that they want her to wait until puberty to see if there's growth. And the
No,
baby, and she's 3. And she's like, how can I just sit there and wait?
no,
Again,
absolutely not.
that's not the
Absolutely not.
team. That's not the team.
Absolutely not. Do not wait. Do not wait until puberty and pregnancy for things to get worse. And then when it becomes too late, you're playing catch up with the malformation. Stay on top of the lesion, stay on top of the problem. It is gonna I mean, just if you can cure it before then, wonderful. Even then, it's gonna require lifelong surveillance. But just get ahead of the lesion, grab the bull by the horn and tame it before it grows like wildfire. And now you're playing catch up, and then they're going to put you on all kinds of meds and say good luck to you, we'll see what happens, and your teenage years are going to be compromised. Again, I haven't seen the patient,
Right.
but that's my philosophy. I'm super aggressive with these. I stay on top of it. And Yeah, that's what I would suggest.
Yep. So we're going to be staying on a little longer because we didn't get started till a little longer. And I know there's some very important questions here. This one's from Rebecca, and this is an important question for you, Dr. Nasseri. Her daughter is 7 years old, and she has what's been diagnosed as a capillary venous lymphatic malformation on her leg, on her hymen, and in her rectal area. She has had multiple lasers, 16 on her leg, as well as 2 on her hymen due to bleeding. She's scheduled for another laser. Are there any other suggestions? Again,
Stop lasering, first of
yeah.
all, right off the bat. Stop. No more laser. Um, Linda, sometimes I don't know what to say aside from I need to see the patient, because like I would get a comprehensive, I sound like a broken record, and I'll say it again. You need someone who knows what they're looking at to evaluate and physically examine your child. You need to, based on that physical examination, that individual will then determine what kind of imaging is going to be required, whether it's catheter directed imaging, duplex ultrasound, and or MRI. There needs to be a comprehensive hematologic evaluation of your child. We need to know what portion of these port wine stains have underlying vascular malformations. And if there are malformations, stop lasering the malformation. You're just poking the bear and making it worse, especially in the genital region. Do not let folks laser your child's genital region unless you have adequately ruled out that any underlying malformation has been adequately treated and devascularized. That would be my recommendation to you.
Yeah, and you know what's so important for all these families to hear from me and you is, you did mention this is multidisciplinary, but like the babies always get sent to like a ped derm, and then that's who they're stuck with. And then the ped derm isn't going to be the interventionalist or someone like you who wants to look at genetic testing and get some blood work done. So remember, all of you, you're in a multidisciplinary disease state, and this really requires an expert, because there isn't a ped derm or a derm. They're great with laser, great with superficial stuff. We have the best laser doctors in the world on our team. But when you start getting compromised in the venous, lymphatic, or arterial, you need to see an interventional radiologist or a vascular surgeon or a intervention, vascular anomalist like yourself. That's why, they're frustrated, is because they're with a ped derm, and they're not getting any more than what the ped derm can do.
Correct.
Ashley said, I saw a neurologist, two neurosurgeons, and had a number of tests, including an angiogram, and none of them can give a diagnosis for what they are seeing in my brain, and I have a port wine stain on my face.
I would have to look at the results of those angiograms. In other words, did they see something that they just don't know what it is, or did they see nothing? So, um, if it's inside the brain, then I would say that you do need to see a dedicated neurointerventional radiologist slash neurosurgeon. I know somebody, I don't go inside the brain myself. I do all around it. I do everything within the calvarium, head and neck, face, tongue, mucosa, all around it. When it comes to the actual brain itself, if you have a true brain AVM, then let me know. I can put you in touch with a good neurosurgeon who is just like me. He's a neurosurgeon who does his own neurointerventional radiology as well. But I would have to look at the reports, and I can, if it's diagnostic alone and there are diagnostic maneuvers that you need, I can perform those diagnostic maneuvers myself, and I can really go all the way up to the skull base. I'm hesitant to go inside the brain myself, but I can definitely get you connected with somebody who is well versed at doing those things for you.
Who is the neurointerventional radiologist that you're referring
I
to?
have to ask him to make sure he's okay with having his name,
Okay.
but let me know off the record, and
All right,
I'll
please,
do that.
because I need to add someone to our website too, because Dr. Berenstein has retired.
Yes, Dr. Berenstein is. I just saw a couple of his patients today alone with a massive facial AVM.
Yeah, he's
Yeah,
retired.
yeah.
So we do have time for this question. So Donna says, my 17-month-old has a segmental hemangioma and face syndrome. She propranolol since 6 weeks, which has worked fabulously. We started the propranolol. I noticed it growing along the beard area and around the mouth as well as the ear. I feel like the regression is different for each section. When she gets laser in London in March, will this help or hinder around the eye area? So we have our free laser clinic, and I'm not sure that you can answer this, but she'll be getting laser, at the clinic in London. But Dr. Comey will be there, so she can talk to her about face syndrome. But I don't know what you could say about that.
Yeah, I mean, if there's port wine stains, certainly laser can help. Hemangiomas are, sort of a different entity. When there are some lingering effects of hemangiomas, we can certainly treat them. But go ahead and attend the screening event, and there'll be a whole slew of people who may be able to kind of help you. I think a combination of propranolol along with laser therapy is a very good option to go. Just remember that the involution period for a lot of these things takes a long time, and they have a variety of different configurations of involution as well. So
Thank you for that. And Rebecca was just making a closing remark. She was saying to thank us and that they go to Boston Children's and visit that team there, and that they see a comprehensive team of derm, surgeon, IR, ortho, and genetics. But she said, I will ask more in-depth questions about doing further testing. So that wraps up our 2024 Facebook Live session with Dr. Nassiri, and I'm happy that I brought you on as the last one of the year because it closes out our 30th anniversary celebration, and everything I've been talking about is innovation and new. And I'm so thrilled that we could end this year and our Facebook sessions with the new innovation and the new techniques. And I observed you treating a young girl with a venous malformation on her back, and it literally took you less than a minute, and she got up the table and went home.
yeah.
And I don't know if you've seen her since, or if there's been any regrowth, or if there will be, or if she's cured, but I was very impressed.
That malformation extended into the lung pleural base, and she was offered a thoracotomy to crack open her rib cage and go out and remove it. And with just that session, we were able to basically cure her of the disease. And I just saw her, and she's trying to get pregnant with her husband.
Well, that is phenomenal. Do you see what, it's a blessing. You're a blessing to these families. You're a blessing to VBF. I want to thank you for your time and your patience, especially because of our little bit of technical difficulty. But thank you. And I look forward to coming and being there in person to see some of the exciting things you're doing. And we will see you again next year. Everybody will see you at our super clinic, and they'll see you at your practice. And hopefully we'll be doing another event there this summer. Stay tuned. We'll be working with Dr. Nassiri's office and his team to see what we can do. But in the meantime, you've seen this string here, Dr. Nassiri's email, reach out, at least get a consultation, at least, if you can make it to Connecticut, let him do it because he sees these and knows these better than anyone else. So thank you, Dr. Nassiri. Happy holidays to you and to your family.
Thank you. There's nothing else like the Vascular Birthmark Foundation. I think 2025 will be we'll leave with this cliffhanger. I think 2025 will be a phenomenal year for malformations, and we look forward to stronger collaboration with really the one and only Vascular Birthmark Foundation and Dr. Linda.
Thank you very much.
Bye-bye.
Bye.
Here for malformations, and we look forward to stronger collaboration with really the one and only Vascular Birthmark Foundation and Dr. Linda.